Hey guys, Mike back with you. One of the questions we're always asked is, hey, when is a review course going to come to my area? The best resource for you is to check FlightBridgeED.com. Courses are being updated almost daily. If there's not one coming next to you, guess what? We've got the fully accredited online university where you can take courses from FlightBridgeED, FoamFrat, and the list goes on. So check out FlightBridgeED.com today for more information. The FlightBridgeED Air and Surface Transport Symposium is back, May 18th through 20th of 2020. Join us in Murfreesboro, Tennessee for our third installment of one of the best EMS conferences in the nation. Guys, I gotta tell you, get to the FlightBridgeED.com website, click on the Fast 20 button, check out all of the pre-conference offerings. We have more than ever this year. Our speaker lineup is going to be incredible. If you've been to Fast 18, to Fast 19, you do not want to miss Fast 20. Go to FlightBridgeED.com, click on Fast 20, get your tickets now. We'll see you in Murfreesboro.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to be our part 2 of our congenital heart defects. As we did part 1, we looked at coarctation and we looked at transposition of the great vessels. In part 2, we're going to look at 2 more. We're going to look at truncus, arteriosus, and we're going to look at Tetralogy of Fallot. So let's get started. Our first one, truncus arteriosus. The big problem with this is you have a single artery that arises from the ventricles. And when you look at this, the artery, this main artery, it actually looks like it's coming up right in between the 2 chambers. So you essentially have one great vessel with one valve. This valve is large. It branches after that into the lungs and body. But when we look at this valve, the valve actually has 2, sometimes up to 5 leaflets. As I said, it sits right above the left and right ventricle, so it splits that opening. The upper part of the 2 chambers is often missing, so that's where we have the associated ventral septal defect. When do we start seeing clinical signs of decompensation in these kids? Well, normally this is going to be identified in the first week of life. A lot of these congenital defects, if they're not initially identified maybe prior to the mom giving birth, the identification is going to be in the first few days or that first week, usually based on that patent ductus arteriosus actually closing. So cyanosis actually ensues. That leads to examination. These kids will often have poor feeding. They're going to be tachypnic. They're going to have the nasal flaring. They'll have retractions and grunting. Once they start working these kids up, they'll maybe give some oxygenation. Oxygenation challenges are not going to work. They're not going to improve. So they'll do chest x-rays, and when they do a chest x-ray, you'll often see on the chest x-ray an enlarged heart. You'll see pulmonary edema bilaterally. They'll palpate the abdomen, and they'll also notice hepatomegaly, so that liver is enlarged. So what do we have to focus on as far as the exams? Well, we have to obviously understand that PDA patency, this is a cyanotic lesion. PDA patency is absolutely essential, so prostaglandin therapy will be initiated. As we said in our previous podcast, that starting dose is 0.03 to 0.1 mics per kilo per minute. The next thing they're going to do, and they do this either at the bedside or in an interventional lab, is going to be to enlarge or stent open that foraminal valve. Remember that foraminal valve is the hole between the right and left atrium, and that closes shortly after that baby is born and they start breathing oxygen. The heart flips from a high pressure right side to a high pressure left side, and that closes that foraminal valve. Well, we need to mix blood. We've got to get blood mixing between those 2 atria because of this problem. So the standard is going to be to enlarge that foraminal valve. The overall surgery is going to be focused on separating the aorta and the pulmonary arteries. So because we have one trunk, there's no separation there. So that's going to be the key, is they're going to separate the pulmonary arteries. That main trunk that this baby was born with, again, remember that single artery is going to now be the new aorta. They're going to separate the pulmonary arteries, and they're going to actually use a conduit or a homograft, and they're going to graft the pulmonary artery to the right ventricle. So that is the main focus of the surgery. While they're in there, they're also going to close the VSD, and that is the main part of the surgery, is obviously separating that main single artery, grafting the pulmonary arteries to the right ventricle, closing the VSD. Remember, prostaglandin therapy, if you get a test question, that can cause apneic spells. That's usually at higher doses. Doesn't mean we automatically intubate every single kid that's on prostaglandin therapy. Obviously, this kid, first weeks of life, is most probably going to be intubated, obviously previous or post surgery. And that is the key to truncus arteriosus, is essentially understanding that single artery, the VSD, and they will, once the baby is doing better, they'll uncannulate that foraminal valve. They'll let the foraminal valve close naturally, and they will reverse or stop the prostaglandin therapy eventually, and that PDA will close. All right, let's go to our second defect, and that is going to be Tetralogy of Fallot. There are 4 main problems with Tetralogy of Fallot, and that is, number 1, these patients are going to have what's called a right upward displacement of the aorta. Number 2, they're going to have a pulmonic valve that is stenotic. They're going to have a pulmonary artery outflow obstruction, essentially, because of that. They're going to have a right ventricular hypertrophy. So that right ventricle is going to be thickened and enlarged based on the high pressures that right ventricle are seeing based on that outflow obstruction through the pulmonary artery because of that stenotic pulmonic valve. And they also have a huge VSD. So that's 4 main problems. Diagnosis, just like before, is in the first weeks of life. Usually based on cyanosis or based on chest auscultation. Listening to heart sounds are going to identify a loud murmur. When we look at Tetralogy of Fallot and we look at the keys to understanding this disease process for test taking, we obviously often hear the term TET spells. TET spells are sudden drops in oxygenation. So the SpO2 is going to drop suddenly, and that's usually due to increased constriction to the outflow tracts of the lungs. These kids are going to show irritability oftentimes. They may become sleepy. They may even go to unresponsiveness. The key is oxygenation is not going to help these kids. This is also considered a cyanotic lesion. That means that giving oxygenation is going to make the problem worse. So if you have a baby that you're dealing with that goes into a TET spell, small babies, you can literally lay them on their back. You can push their knees to their chest. That seems to help, right? That pushes pressure up into their chest. Once babies start crying, that seems to help as well. Again, changes the pressure in the chest as well. Infants are often very sick after surgery. So what do they do with the surgery? Obviously, you have 4 main problems. The key is going to be to fix that stenotic pulmonic valve, which is going to obviously fix that pulmonary artery outflow obstruction. The right ventricular hypertrophy, or the thickening of that RV, is just going to have to heal over time. There's really not a lot they can do there, and they can't really fix that right upper displacement of the aorta. So the key is, after surgery, or prior to surgery, we'll say, prostaglandin therapy is going to be initiated again at the same dose regimen. Again, that's the low dose regimen. And they are going to start and do this surgery in the first year. So it could be the first week. It's going to be all dependent on how severe. And I should also say that a lot of times these kids have actually multiple heart defects. This child may have Tetralogy of Fallot, but they also may have something else. They may have transposition of the great vessels. They may have, coarctation as well. So that's going to guide the overall therapy as far as how quickly this baby goes into surgery or how long they wait. Let's say they go to surgery, they come back out. Nowadays, 95% of babies that are fixed, or these Tetralogy of Fallot kids are fixed, survive. So that's great. And they survive up to that first year of life. Infants are often sicker, as I said, and that's because when they come out of surgery, they often have a right ventricle that is very stiff. They could have tachyarrhythmias or bradyarrhythmias. So these tachyarrhythmias are a manifestation of a stiff right ventricle, and they'll go into junctional tachycardia as a secondary aspect of that. Once that right ventricle starts healing and gets better, that junctional tach will go away. It'll fix itself. Along those same lines, these kids can go into heart blocks. They can go into second degree and third degree heart blocks, and that is secondary to inflammation or injury to the conduction system based on the surgery itself. So what do we need to know? We need to know that these kids are ductal dependent. They have to have prostaglandin therapy. The surgery is multifaceted. They're going to have a step-by-step approach in fixing that pulmonic valve, in that outflow obstruction. That VSD is going to be patched, and this is going to be something that is going to be ongoing. Once these children heal and they progress to adolescence up into adulthood, there's going to be constant reevaluation by the cardiologist that handled this case. There could be medication administration throughout their life, but usually these kids do fairly well. So when we think about these congenital defects, the keys are going to be to identify in your mind, is this going to be a cyanotic or acyanotic lesion? The hint I want to give you is that really everything is treated pretty much the same as far as maintaining ductal dependency, maintaining that PDA in a patent state. When we look at just strictly VSDs, for example, if those are isolated, are considered an acyanotic lesion, meaning that it's not necessarily important to have the PDA patent for oxygenation purposes. But what we see there is that you have an overloaded left ventricle. That causes an overload through the mitral valve into the pulmonary side and causes CHF. And so having that second outflow tract, for example, in a just an isolated VSD, even though it's not a cyanotic lesion, actually helps reduce that pressure, that afterload in that left ventricle. So the key is just always understand that PDA patency is important, prostaglandin therapy is important, and usually oxygenation is not going to be the mainstay. That's going to actually worsen these kids. We have to know that oxygenation causes pulmonary vasodilation, which increases pulmonary blood flow. And in these kids that are already overloaded, oftentimes have secondary problems with congestive heart failure and pulmonary hypertension. That makes the problem much worse. So hopefully, guys, this helps. Again, these are just 2 more out of our 3-part series. Until next time, I will talk to you soon.
This has been a production of the FlightBridgeED podcast, leading the way in pre-hospital critical care and emergency medicine education.